Hello everyone, my name is Shukri Sala. This presentation focuses on testicular torsion, a time-sensitive urologic emergency in children and adolescents. In this presentation, we will discuss disorder overview, name, alternate names. We will discuss etiology, pathophysiology, chief complaint, and presenting symptoms. And then past medical history, family history, social history. We will discuss physical exam findings, imaging, and diagnostic tools that are used in this case. And then we will also discuss immediate intervention therapies, referral and follow-up, specialist referrals, patient and family education. We'll also have differential diagnosis and ICD-10 and billing codes. Primary name is testicular torsion. Some names that are used interchangeably is spermatic cord torsion, intravaginal torsion, extravaginal torsion as well. Testicular torsion is estimated to occur 1 in 4,000 males under the age of 25. Bimodal incidence, neonatal period, and puberty. Increased incidence during puberty, likely due to testicular growth and cremasteric reflex stimulation. So I found this male reproductive organ diagram in the Urology Care Foundation, the American Urology Association. The testicles are the primary male reproductive organs housed in the scrotum below the penis. They serve two critical functions, producing sperm for reproduction and manufacturing testosterone, the primary male hormone. Each testicle receives blood supply through the spermatic cord, which originates in the abdomen and extends down into the scrotum. The same cord contains vas deferens, the pathway that transports mature sperm from the testicles to the urethra. Intravaginal torsion is due to abnormal attachment of the testes to the tunica vaginalis. Most commonly, the bell clapper deformity. This permits the testes to rotate freely within the scrotum, leading to twisting of the spermatic cord. Torsion causes venous outflow obstruction followed by arterial occlusion and ischemia. Testicular viability declines sharply over time. So less than 6 hours up to 100% salvage. As time increases, 12 hours, 20 to 60% chances of testicular salvage, and then 0 to 24% within for the chances for the testicular salvage within 24 hours. Sudden severe scrotal pain is the hallmark sign. The testes should be about the same size. If one side quickly becomes larger than the other, this can be a problem. Change in scrotal color, especially redness or darkening, is also a problem. Early on, there may not be swelling, but very shortly after, their scrotal skin will swell and turn red. Patient may also feel nauseous and vomit. And then about 90% of patients complain of nausea and vomiting. Pain may radiate to the lower abdomen or cause sleep disturbance. Some children may report intermittent prior episodes. And it's important to note that some may present with only abdominal pain. So when conducting patient history, it's important to ask about prior undescended testes, past scrotal pain, or prior surgery. What's also important is to ask about family history of torsion. That's really relevant. And ask about cold exposure, ask about trauma, ask about physical activity. Some key questions to include is timing. When did this start? It's very important that we find out, when it first started, so we're able to get them the intervention if it is testicular torsion. And then previous episodes, any prior urologic issues. All of these things are important to consider when thinking about our differentials. So on physical examination, we are looking for high riding, transversely lying testes. Scrotum may be swollen, red, and tender, firm and displaced. And then absent cremasteric reflex is a reliable sign also. Clinical evaluation is important. Do not delay care for imaging. Use the TWIST score for clinical guidance. Doppler ultrasound may show reduced blood flow or the whirlpool sign. And sensitivity is 69 to 100%. Specificity is 77 to 100%. Nuclear scan is accurate but impractical due to delays. Some medications we can offer patients is ibuprofen, acetaminophen, or Zofran for symptom control. Manual detorsion may be attempted if surgery is not immediately available. Definitive treatment is surgical detorsion and bilateral orchiopexy. If testicle is non-viable, orchiectomy is performed. So complementary and alternative treatments are not really an option for this since this is really an emergency. So we would provide supportive measures for post-op, like warm compresses. It could help aid comfort. And then psychological support is also important in adolescents after orchiectomy. Manual detorsion may offer temporary relief, but surgery is essential. Counseling and emotional support post-orchiectomy is key. Some referral options would include immediate pediatric urology consultation. But of course, if they come into our office, we would send them to the emergency to get urgent care, emergency care, and an emergency care that is warranted for testicular torsion. So follow-up care would be post-op follow-up with pediatrician and which is the primary care provider, and psychological support. We would send them to behavioral health and try to find them support there. So patient and family education, that this is a time-sensitive emergency. Teach them and to recognize the symptoms early, discuss the importance of not waiting for pain to improve, and address concerns about fertility and long-term outcomes. And, future vigilance into, reporting of testicular discomfort in the future. So some continued patient education I found on the American Urology Association was some questions that families might ask and the answers that came along with them. And so we can, if they ask questions about fertility and hormones, you can reassure them that one testicle is enough for normal fertility and testosterone. And then 1/3 may have reduced sperm count or anti-sperm antibodies. And then routine testosterone checks may be needed over time. Lifestyle considerations would be protect and remaining testicles during sports. And then seek care for any discomfort or changes. And then testicular prosthesis is a cosmetic option for after puberty. So types of torsions, newborn torsion is rare, usually painless, often not salvageable. And then appendix testes torsion affects non-functional tissue. And it's more common in pubescent boys. Some differentials we could consider is ependymitis. Gradual pain would be the symptoms, and then urinary symptoms, and then positive prine sign. Torsion of appendix, testes, blue dot sign, milder in pain. And then incarcerated hernias would be something like a inguinal mass, and then trauma, bruising or injury history, hydrocele or varicele, chronic swelling, typically non-tender. Coding and billing information. So ICD-10 N44.00, torsion of testes, unspecified, and then CPT code 55430 would be used in a surgical setting. We are primary care, so we would use the office visit 99214 or 99215, depending on the complexity of the situation. Here are my references. Thank you all for listening, and feel free to ask questions.